Welcome to This Week in Otolaryngology. This week we're covering 10 notable papers spanning airway and breathing interventions from the larynx to the sleep laboratory, thyroid and head and neck oncology decision-making, and a set of studies on measurement, rehabilitation, and pediatric safety. Let's dive in. We'll start with the airway, where 2 papers challenge how we treat obstructed breathing at very different anatomical levels. In the laryngoscope, Sandvik and colleagues report what is, remarkably, a randomized surgical trial in exercise-induced laryngeal obstruction, a condition where surgery has long outpaced evidence. 41 patients with symptomatic supraglottic obstruction, despite conservative management, were randomized to full supraglottoplasty, a minimally invasive laser puncture supraglottoplasty, or a wait-and-see control arm, with continuous laryngoscopy during exercise before and after. Full supraglottoplasty was superior to control for supraglottic obstruction at moderate intensity and for both glottic and supraglottic obstruction at maximal exercise, and it also outperformed the minimally invasive procedure at maximal intensity. Importantly, the minimally invasive approach did not differ from doing nothing on any objective laryngoscopy outcome, even though patients in that arm reported less breathing difficulty during activity. A reminder of how powerful expectation effects are in a symptom-driven condition. The practical message is that if you are offering surgery for refractory, supraglottic, exercise-induced laryngeal obstruction, the full aryepiglottic fold procedure is the one with randomized support, and the laser puncture variant should be regarded as unproven. Staying with breathing but moving to sleep, Otolaryngology-Head and neck surgery publishes a systematic review and meta-analysis from Loblundo and colleagues on glucagon-like peptide-1 receptor agonists in obstructive sleep apnea. 5 randomized trials covering around 950 patients using liraglutide or tirzepatide showed a reduction in the apnea-hypopnea index of about 12 events per hour beyond control, a clinically meaningful shift in severity category for many patients, and crucially, this held whether or not patients were also using continuous positive airway pressure. Weight loss was substantially greater, waist circumference fell by roughly 3 centimeters, and systolic blood pressure dropped by around 4.5 millimeters of mercury, at the cost of more gastrointestinal side effects. For the sleep surgeon, this reframes the pre-surgical conversation. Pharmacological weight management is now a legitimate parallel arm of therapy rather than vague lifestyle advice, and it may change the anatomy and the apnea burden you are operating on. Turning to thyroid and head and neck oncology, 3 papers converge on the question of how aggressively to treat and on what basis. The most conceptually important comes from JAMA Otolaryngology-Head and neck surgery, where Marchik and colleagues examined the interplay of age, TERT promoter variants, and survival in papillary thyroid carcinoma across more than 1,500 patients, drawn from 3 academic centers, plus public genomic cohorts. The prevalence of TERT promoter variants rose steadily with age, under 2% in patients younger than 30, but between roughly 1/3 and 2/3 of tumors in patients over 65. In the long follow-up cohort, patients under 55 without a TERT variant had 100% 10-year disease-specific survival. Among those 55 and older, 10-year disease-specific survival was 91% for wild-type tumors, but only 51% when a TERT variant was present, and the variant remained independently prognostic after adjustment for age and tumor, node and metastasis category. The authors argue that age in our staging system is largely a surrogate for underlying biology, and that molecular status offers more grounded risk stratification than a birthday. That theme of recalibrating aggressiveness continues in the laryngoscope, where Erjink and colleagues retrospectively reclassified 98 hemothyroidectomy patients under both the 2015 and the 2025 American Thyroid Association criteria. Eligibility for hemothyroidectomy alone rose by about 21 percentage points, from roughly 60% to just over 80%, and the proportion with a guideline indication for completion thyroidectomy fell by about 15 points. Yet completion was actually performed in around 40% of the cohort, more than either guideline projected, suggesting that surgeons are responding to pathological and clinical nuances the criteria don't capture. This is hindsight reclassification using final histopathology, so it tells us about guideline impact, not about oncologic outcomes. Read alongside the TERT data, the direction of travel is clear: less reflexive completion surgery, more biologically informed selection. And in head and neck, Nielsen and colleagues address subsite anatomy in transoral robotic surgery, reviewing 153 consecutive patients with pathological T1 to T2 oropharyngeal squamous cell carcinoma. The 52 patients whose tumors involved the glossotonsillar sulcus had significantly worse overall survival, fewer clear margins, and more perineural invasion. If your resection crosses that sulcus, counsel the patient accordingly and anticipate a higher likelihood of adjuvant therapy. A third cluster concerns how we measure, image, and rehabilitate. Also in JAMA Otolaryngology-Head and neck surgery, Bartle and colleagues make the case for intentional imaging in primary hyperparathyroidism, laying out the radiation cost of each modality. Ultrasound carries no ionizing radiation. Sestamibi single-photon emission tomography delivers roughly 9 to 12 millisieverts. Four-dimensional computed tomography can reach 20 millisieverts, and choline positron emission tomography sits around 7 to 12. Their prescription is straightforward. Confirm the biochemical diagnosis before you image at all, reserve the higher-dose second-line studies for revision surgery, and weigh local expertise and cost alongside sensitivity. In the same measurement vein, Otolaryngology-Head and neck surgery publishes work from Lichien establishing minimal clinically important differences for laryngopharyngeal reflex instruments in 351 patients with pH impedance-confirmed disease. The thresholds are a drop of 35 points on the reflex symptom score, 20 points on the 12-item version, and 8 points on the reflex symptom index. That last number is directly usable in clinic. It gives you a defensible benchmark for declaring treatment response and beginning to wean therapy rather than continuing proton pump inhibitors indefinitely. Rounding out the week, the laryngoscope reports a single-blind randomized trial from Karasley and colleagues in vestibular migraine, where 40 patients received 4 weeks of home vestibular rehabilitation with or without 8 clinic-based virtual reality sessions. The virtual reality group had significantly lowered dizziness handicap inventory scores, with a reduction exceeding the 18-point clinically important threshold, lower dizziness visual analog scores, and better dynamic limits of stability. However, there was no difference in sensory organization test composite scores or in functional head impulse testing, and both groups improved on the psychological and functional measures, so the added value is real, but narrower than the headline suggests. Finally, a sobering pediatric safety study, also in the laryngoscope, from Ramasamy and colleagues comparing button battery retrievals across 2 5-year windows. Button batteries rose from about 2% to about 4% of all foreign body retrievals. Mean battery diameter increased from roughly 14 to 19 millimeters, and esophageal impactions tripled in number. Critically, caregiver estimated time before emergency department arrival accounted for 86% and then 95% of total exposure time, and long-term morbidity or death occurred in about 1 in 10 esophageal cases, including a fatality. Hospital triage to theater time was not the bottleneck. The lever here is public awareness, not workflow optimization. If you only have time for one paper this week, make it the TERT promoter analysis in JAMA Otolaryngology-Head and neck surgery. It offers a credible biological explanation for why age drives thyroid cancer staging, and it points toward molecular testing displacing a crude age cutoff in how we counsel and follow these patients. Here are the key takeaways from this week in otolaryngology. First, full supraglottoplasty has randomized support in refractory exercise-induced laryngeal obstruction, while the minimally invasive laser puncture variant improves symptoms without changing objective obstruction. Second, glucagon-like peptide-1 receptor agonists cut apnea severity by about 12 events per hour, regardless of positive airway pressure use, and belong in your sleep apnea discussions. Third, TERT promoter status outperforms age as a prognostic marker in papillary thyroid carcinoma, and the 2025 American Thyroid Association criteria meaningfully expand hemithyroidectomy eligibility. Fourth, glossotonsillar sulcus involvement predicts worse survival and more positive margins after transoral robotic surgery. And fifth, an 8-point drop on the reflex symptom index is now your benchmark for meaningful reflex improvement, while for button batteries the dangerous delay happens at home, before the child ever reaches you. That's your roundup for this week in otolaryngology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And a quick rating on Apple Podcasts or Spotify helps other physicians discover the show. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.